Chapter 40, Med-Surg by Timby, Caring for Clients with Neurologic Deficits. Learning objectives. Define a neurologic deficit. Describe the 3 phases of a neurologic deficit. Give the primary aims of medical treatment of a neurologic deficit. Name 6 members of a healthcare team involved with the management of a client with a neurologic deficit. Describe nursing management of a client with a neurologic deficit. This chapter discusses the management of a client with a neurological deficit, a condition in which one or more functions of the central and peripheral nervous systems are decreased, impaired, or absent. Examples include paralysis, muscle weakness, impaired speech, inability to recognize objects, abnormal gait or difficulty walking, impaired memory, impaired swallowing, or abnormal bowel and bladder elimination. The client with a neurologic deficit faces many problems. Often the deficit affects more than one body system. The client may be unable to walk, talk, perform simple tasks such as feeding and bathing, or recognize family members. Many members of the healthcare team are involved in the complex management of the client with a temporary or permanent neurologic deficit. The physician, nurse, nursing assistant, social worker, physical therapist, occupational therapist, speech therapist, prosthetist, psychotherapist, dietitian, pharmacist, and vocational counselor. With intensive therapy and a coordinated approach by all team members, many clients have the potential to regain normal or near normal function or successful adaptation to functional changes. Phases of a neurologic deficit. Neurologic deficits are divided into 3 phases: acute, recovery, and chronic. Not all clients with a neurological deficit experience all 3 phases. Some clients have deficits that begin with an acute phase and move into a recovery phase or into a lifelong chronic phase. Acute phase. The acute phase follows a sudden neurological event such as a cerebrovascular accident, abbreviated CVA, or a head or spinal cord injury. During the acute phase, the client is usually critically ill with many signs and symptoms such as altered level of consciousness, which is abbreviated LOC, hypertension or hypotension, fever, difficulty breathing, or paralysis. Question: is the following statement true or false? One or more functions of a CNS or PNS are decreased, impaired, or absent with a neurological deficit. The answer is true. One or more functions of a central nervous system or a peripheral nervous system are decreased, impaired, or absent with a neurologic deficit. Acute phase. The acute phase follows a sudden neurologic event such as a cerebrovascular accident, a CVA, or a head or spinal cord injury. During the acute phase, the client is usually critically ill with many signs and symptoms such as altered level of consciousness, which is abbreviated LOC, hypertension or hypotension, fever, difficulty breathing, or paralysis. Medical and surgical management. The focus of management during the acute phase is to stabilize the client and prevent further neurologic damage. The client with a CVA may require management of hypertension or hypotension through drug therapy. The client with a head or spinal cord injury may require respiratory support through mechanical ventilation or surgical intervention to stabilize the injured area or remove bone fragments, blood clots, or foreign objects. Sometimes surgery is postponed until the client is stabilized and the acute phase is passed. In other instances, surgery is performed during the acute phase as a life-saving measure. Nursing management. The nurse performs frequent and thorough neurologic assessments to evaluate the client's status, need for additional medical or surgical interventions, and response to treatment. He or she uses the Glasgow Coma Scale, see Chapter 36, or other neurologic assessment tools such as the Mini Mental Status Examination, see Chapter 67. When significant changes occur, the nurse immediately reports them to the physician. The nurse assesses vital signs as often as necessary and maintains the blood pressure to ensure adequate cerebral oxygenation. He or she measures intake and output and observes for signs of electrolyte imbalances and dehydration. The nurse reports a urinary output of less than 500 milliliters per day or urinary or bowel incontinence. Beginning basic rehabilitation during the acute phase is an important nursing function. Measures such as position changes and prevention of skin breakdown and contractures are essential aspects of care during the early phase of rehabilitation. The nursing goal is to prevent complications that may interfere with the client's potential to recover function. For additional nursing management, see the nursing process section. Recovery phase. The recovery phase begins when the client's condition is stabilized. It starts several days or weeks after the initial event and lasts weeks or months. Medical and surgical management. Medical management during the recovery phase aims at keeping the client stable and preventing or treating complications such as pneumonia and further neurologic impairment. Nursing management. During recovery, the nurse works with team members to plan a rehabilitation program in several domains according to the client's abilities and limitations. See Table 40-1. Various assessment tools can help identify a client's level of functioning and potential for improvement with a rehabilitation program, including the National Institutes of Health Stroke Scale, the American Heart Association Stroke Outcome Classification, the Barthel Index. Table 40-2. Table 40-1, Domains of Neurologic Impairment. Domain is motor. Description, a single deficit or combination of deficits involving the face, arms, and legs, which affects speech, swallowing, muscle tone and strength, gait, coordination, and ability to use objects for their intended purpose. Sensory domain, altered sensation like numbness, tingling, exaggerated sensation, or altered perception such as inability to identify objects by touch and loss of writing ability. Vision, loss of vision in one eye or in the temporal or nasal fields, and blindness. Language, disturbances in comprehension, naming, repeating, clarity of speech, and reading. Cognition, changes in memory, attention, orientation, calculation, and construction. Affect, A-F-F-E-C-T, affect, altered mood and lability of mood, means mood swings. Rehabilitation is designed to meet the client's immediate and long-term needs. Environmental changes may be necessary to help the client adapt to the disability and fully regain any remaining functions. Even though deficits can be temporary, a prolonged period and enrollment in a rehabilitation program are often necessary before recovery of partial or full function can occur. A successful rehabilitation program includes not only nurses and physicians, but also several other providers, such as physical therapists, occupational therapists, speech therapists, and enterostomal therapists, all of whom recommend devices or procedures to prevent complications and enhance the client's remaining abilities. Enterostomal therapists, which work with ostomies. With continuous assessment and identification of the client's needs, the nurse plays an important role in rehabilitation. Devices that help a client walk, eat, groom, and perform other motor skills are recommended or devised to suit particular needs. Flotation pads for wheelchairs, walkers, padded ankle foot boots to prevent foot drop, and range of motion exercises are examples of the many appliances and procedures used in rehabilitation. For additional nursing management, see the nursing process section. Chronic phase. For some clients, such as those with amyotrophic lateral sclerosis, known as ALS, also known as Lou Gehrig's disease or Alzheimer's disease, neurologic deficits result in a prolonged or lifelong chronic phase. In this phase, the client shows little or no improvement, remains stationary, or progressively worsens. Physical and psychologic rehabilitation continues in the chronic phase to prevent complications such as pressure ulcers and muscle contractures. Medical and surgical management. Medical management continues throughout the chronic phase and uses a wide range of therapies and treatments, such as control of blood pressure, physical therapy, dietary management, and treatment of complications related to disuse and immobility. In some cases, surgery is performed to correct deformities or problems that have developed. Examples include muscle and skin grafts to close a pressure ulcer, surgery to correct a contracture deformity, or removal of a kidney stone, a complication of prolonged immobility. Nursing management. Clients in the chronic phase are often admitted to a hospital for treatment of complications. They are also transferred to a skilled nursing facility or long-term care facility when family members no longer can manage their care or when the disease has progressively worsened so that skilled care is mandatory. Nursing management focuses on preventing physical and psychological complications. Therapy in a rehabilitation center may include retraining in skills such as using the telephone, handling money, shopping, using public transportation, maintaining a household, and vocational training. In review, primary aims of medical treatment. Focus of management during the acute phase is stabilizing the client, prevent further neurologic damage. Medical management during the recovery phase is keeping the client stable, preventing or treating complications such as pneumonia and further neurologic impairment. Physical and psychological rehabilitation continues in the chronic phase to prevent complications such as pressure ulcers and muscle contractures. Question: is the following statement true or false? Medical management during the chronic phase aims at keeping the client stable and preventing or treating complications such as pneumonia and further neurologic impairment. Answer: false. Medical management during the recovery phase aims at keeping the client stable and preventing or treating complications such as pneumonia and further neurologic impairment. Physical and psychological rehabilitation continues in the chronic phase to prevent complications such as pressure ulcers and muscle contractures. Healthcare team management. Team members include physician and nurses, the nurse's assistant, social worker, physical therapist, occupational therapist, speech therapist, prosthetist, dietitian, psychotherapist, pharmacist, and vocational counselor. Psychosocial issues and home management. It can be tremendously frightening to leave the inpatient setting, where the daily intensive support of the healthcare team is readily available, and return home with life-altering changes. The client and family need additional support to adapt to a new lifestyle. Although many clients recover sufficiently to assume responsibility for some aspects of their own care, others do not. The burden of care often falls on the spouse, who may have physical problems as well, or the adult children, who may not be available or willing to share this responsibility. Financial resources are strained during a lengthy hospitalization and may continue after discharge. Adapting the home to accommodate a wheelchair or special bed can be costly. Wide doorways, ramps instead of stairs, and special fixtures in the bathroom for bathing and toileting are examples of changes that are often necessary. The client may have been the major wage earner. Some clients can enter training programs that allow them to find employment outside the home, whereas others can learn skills that enable them to be employed at home. Others, because of their age or extreme physical disability, cannot be gainfully employed. Nursing management. The nurse listens and is alert to subtle hints about the client's and family's adaptation to the client's change in functional status. The nurse asks direct questions to identify problems and needs. He or she evaluates the client's ability to perform self-care, resume his or her role in the family, and call on a support system. The nurse takes appropriate steps to help the client and family attain and maintain a home life as near as normal as possible. For example, the nurse assesses available facilities, the family support system, physical aids required, such as wheelchair, cane, and walkers, and the amount of assistance the client requires with activities of daily living. He or she encourages the family to help plan for the client's return home, to ask questions about care, and to seek assistance from those agencies that can provide emotional, physical, and financial support. Coping. The nurse addresses each client's status individually. He or she offers reassurance and emotional support and displays empathetic understanding of the multiple problems that the client is facing. Many clients have difficulty coping with their disability. Crises such as being unable to move, having limited movement, being unable to attend to one's most basic needs, and having to totally depend on others for housing, clothing, mobility, and food generate strong emotional responses. Some clients eventually accept their disability, whereas others do not. The nurse provides encouragement and praise throughout rehabilitation and shows personal interest and pleasure in each accomplishment. The nurse provides encouragement and praise throughout rehabilitation and shows personal interest and pleasure in each accomplishment, no matter how small, to help clients accept what they cannot or never will be able to do. The nurse gives clients time to talk about their problems, fears, and concerns. Once needs are identified, he or she encourages the client to set attainable goals, which may help maintain independence as long as possible. The nurse works with the client and family to develop solutions and possible alternatives. This helps the client and family meet each problem as it arises, understands the limitations, establishes goals, and works toward a solution. With rehabilitation comes the client's awareness of progress or lack thereof. At times, improvement is slow and barely noticeable. A client has often difficulty coping. Discouragement, depression, withdrawal, and anger are not unusual. The nurse suggests available support groups for those with neurologic deficits for emotional, physical, and social support. Gerontologic considerations. The slower response to stimuli that may accompany aging can lead to increased frustration, irritability, or depression. Socialization. As soon as clients can respond to those around them, the nurse encourages socialization with others. However, communication difficulties may create barriers that some may interpret as a lack of intelligence. Clients with neurologic deficits may have one or more of the following problems that affect communication: expressive aphasia, APHASIA, the inability to produce language but may be able to write information; receptive aphasia, the inability to understand spoken or written language but may retain the ability to understand very common words that are used most often; dysarthria, DYSARTHRIA, is difficulty using the tongue, lips, palate, vocal cords, larynx, or breathing to produce speech. For interacting with clients with neurologic deficits, refer to Nursing Guidelines 40-1. Interacting with clients with a neurologic deficit. Receptive aphasia. Technique: gain the person's attention, provide sensory aids such as glasses, limit environmental distractions such as background noise or multiple people talking, use gestures, facial expressions, drawings, and pictures, speak in a normal tone of voice, use simple language on one topic at a time. Expressive aphasia. Technique: provide a list of words for the client's reference or use a communication board. Refer to Chapter 7. Allow time for a response. Guess the word the client has difficulty saying and ask if it is correct. Do not interrupt when the client speaks. Admit that you do not understand. Limit questions to yes or no answers. Dysarthria. Technique: consult with a speech therapist. Practice exercises recommended by speech therapists such as whistling, blowing bubbles, balls, or through straws. Use a communication board or software. Encourage changing the rate of speech. Suggest pausing briefly between words. Have the client write the word that is not understood. Utilize prosthetics such as a dental retainer. Enlist the aid of a speech-generating device for creating a synthetic voice. At first, socialization can be limited to healthcare team members and family. The nurse encourages the family to talk to the client, discuss current events, and motivate the client to respond. Speech, occupational, and recreational therapies may be part of the rehabilitation program and require a team effort. In the beginning, speech and occupational therapies are designed to help strengthen the muscles that are under voluntary control. Later, certain tasks are learned or relearned to help the client interact with others. Participation in these therapies increases socialization time and helps the client interact with others. Gerontologic consideration. Older adults with a neurologic deficit may lack an adequate support system once they are discharged from the hospital. Involve social service and other agencies to assist these clients and their caregivers with rehabilitation and to prevent social isolation. For example, older adults without family may connect with others through past church or community involvement, to schedule a brief phone conversation each morning or evening, or to obtain transportation to events of interest. Family processes. The nurse recognizes that the family faces many disruptions because of the permanent disability of a family member. Lifestyles are altered, financial resources are strained, conflicts arise, and people must accept new responsibilities. The nurse allows the family time to deal with and accept these changes. The nurse provides the family with opportunities to talk and openly express their anger, fears, guilt, and helplessness. Although no single perfect solution to any problem exists, the following suggestions may help the family adjust to present and future changes. Include the family in the client's rehabilitation. Give encouragement and praise when a family member is able to help with a part of home care or shows interest in becoming involved in the client's care. Explain the purpose of each segment of rehabilitation, such as range of motion exercises and positioning. When the family expresses a desire to assume responsibility for certain procedures at home, teach each skill or task slowly and give the family time to practice under supervision. Prepare a list of public or private agencies that may assist with home care, transportation, and financial and emotional support. Client and family teaching. The nurse develops a teaching plan for home care management that incorporates the therapies prescribed by the physician and other members of the team. The client and family have usually many questions. The nurse must begin teaching long before discharge so that the client and family have sufficient time to learn and understand home care management. The individualized teaching plan includes discussions of the topics presented in Client and Family Teaching 40-1. Nursing process. Assessment. Obtain a thorough history, including drugs and allergies, from the client or family. Assess vital signs and level of comfort. Weigh the client for future comparisons. Perform a general neurologic assessment and use a standardized assessment tool, see Table 40-2, to note the extent of neurologic deficits related to swallowing, vision, weakness, or paralysis of extremities, speech, and language comprehension. Evaluate airway, breathing, circulation, and level of consciousness. Inspect the skin, auscultate the abdomen for bowel sounds, palpate the bladder for distension, and determine the client's ability to control bowel and bladder. Explore the client's emotional and mental status, such as stability of mood, evidence of depression, and motivation for rehabilitation. Determine if the client is at risk for falls. See Evidence-Based Practice 40-1. Diagnosis, planning, and interventions. In addition to the diagnoses discussed in the following section, many nursing diagnoses may apply for the client and family facing a neurologic deficit. See Box 40-1. Risk for impaired skin or tissue integrity is one. Disuse syndrome is another. Constipation or diarrhea related to prolonged immobility, tube feedings, decreased fluid intake, affective disease or injury on the spinal cord nerves. Total urinary incontinence or urinary retention, impaired physical mobility, risk for sexual dysfunction, risk for injury, risk for situational low self-esteem, risk for dysfunctional grieving, and evaluation of expected outcomes for the risk for skin impairment. Skin will remain intact and free from infection. For expected outcomes for risk for disuse syndrome, the client will maintain range of motion in all joints. The use of constipation or diarrhea diagnosis, the expected outcome would be client will have regular bowel movements at least every 3 days. Total urinary incontinence or urinary retention, the expected outcome the client will void, the bladder will empty with no urinary retention or both. Impaired physical mobility, the expected outcome would be client will tolerate increased physical mobility as demonstrated by use of devices for mobility and remain free of contractures. Risk for sexual dysfunction, client will explore sexual alternatives. Risk for injury, client remains free from injury as the outcome or expected outcome. Risk for situational low self-esteem, the expected outcome would be the client will maintain positive self-regard, accept changes in body function, express feelings about the disability, and participate in rehabilitation. Risk for dysfunctional grieving, the expected outcome would be client will adapt progressively through various stages of grieving, and a behavioral or cognitive change such as irritability may be the only sign of urinary retention, just a sidelight, in older adults with a neurologic deficit. Functional problems and diminished muscular strength that accompany aging may complicate recovery for a client with a neurological deficit. For example, an age-related delay in the relaxation of the internal bladder sphincter can make bladder training more difficult. Is the following statement true or false? Neurologic deficits only affect the nervous system. False. Neurologic deficits often affect more than one body system. And this is the end of the slideshow.